Fallopian tube carcinoma, FTC, is an exceedingly rare malignancy that originates from the epithelial lining of the fallopian tubes, the pair of slender conduits that transport ova from the ovaries to the uterine cavity. Although the tubes are only a few centimeters in length, they are lined with secretory and ciliated cells that can undergo malignant transformation. FTC represents a distinct clinical entity, separate from ovarian and uterine cancers, and its rarity often leads to misdiagnosis or delayed recognition. Understanding the anatomical context, how the tubes sit within the pelvic sidewall, adjacent to the ovaries, uterus, and broad ligament, helps clinicians appreciate why FTC may present with vague pelvic symptoms that mimic other gynecologic conditions. The precise inciting events that trigger FTC remain elusive, but several epidemiologic and molecular risk factors have been identified. The most compelling evidence points to germline mutations in the B, RCA1 and B, RCA2 tumor suppressor genes, which dramatically increase the lifetime risk of pelvic serous carcinomas, including those of the fallopian tube. Women who inherit these mutations often have a family history of breast or ovarian cancer, suggesting a shared pathogenic pathway. In addition to hereditary factors, prolonged exposure to endogenous or exogenous estrogen, such as that seen with early menarche, late menopause, or hormone replacement therapy, may promote epithelial proliferation, providing more opportunities for DNA errors. Lifestyle elements, including smoking and obesity, have been investigated but lack consistent association. In practice, a 55-year-old woman with a known BRCA1 mutation and a history of breast cancer would be counseled about her heightened FTC risk and offered intensified surveillance or prophylactic surgery. FTC begins when normal tubal epithelial cells acquire genetic and epigenetic alterations that confer proliferative advantage, inhibit apoptosis, and enable invasion. The most common molecular signature mirrors that of high-grade serous ovarian carcinoma, TP53 mutations, loss of homologous recombination repair, and overexpression of oncogenes such as MYC. As these transformed cells accumulate, they form intra-tubal papillary projections that can breach the tubal muscularis. Once the basement membrane is breached, malignant cells infiltrate the peritoneal cavity, seed the ovarian surface, and disseminate via transcolomic routes to the omentum and pelvic peritoneum. This cascade explains why many patients present with peritoneal carcinomatosis, despite a seemingly small primary lesion. Clinically, the pouch of Douglas often harbors early implants, leading to pelvic pain and a sensation of fullness. Fallopian tube carcinoma accounts for less than 1% of all female reproductive tract malignancies, translating to roughly 100 to 200 new cases per year in the United States. The disease predominantly affects postmenopausal women, with a median age at diagnosis of 58 to 62 years. A striking epidemiologic pattern is the overrepresentation of BRCA mutation carriers. Up to 20 to 30% of FTC patients harbor pathogenic BRCA1/2 variants, compared with less than 1% in the general population. Racial and ethnic distribution appears similar across groups, although most data derive from white populations due to limited representation in registries. Because of its rarity, many oncologists encounter FTC infrequently, which contributes to the paucity of large-scale prospective trials. Patients with FTC typically present with nonspecific pelvic complaints that overlap with benign gynecologic conditions. The most common symptom is abnormal vaginal bleeding, which may be postmenopausal spotting or intermenstrual flow. Pelvic or lower abdominal pain, often described as a dull ache or pressure, arises from tubal distension or peritoneal irritation. A sense of abdominal fullness or early satiety can signal ascites or peritoneal implants. Occasionally, a watery or blood-tinged vaginal discharge occurs, reflecting tubal secretions leaking into the uterine cavity. Because these signs are vague, clinicians must maintain a high index of suspicion, especially in women with known BRCA mutations or a strong family cancer history. Diagnosing FTC requires a multimodal approach. A thorough pelvic examination may reveal a firm adnexal mass or thickened tubal segment. Transvaginal ultrasound is the first-line imaging tool. It can detect a tubular solid cystic lesion with irregular borders. For further anatomical detail, contrast-enhanced CT or MR delineates the extent of disease and identifies peritoneal implants or lymph adenopathy. Serum CA-125 is frequently elevated, but lacks specificity. Definitive diagnosis hinges on histopathologic confirmation, usually obtained via laparoscopic salpingectomy or intraoperative frozen section. Pathologists look for high-grade serous features, papillary architecture, and immunohistochemical markers, for example, p53 overexpression. In ambiguous cases, a staging laparoscopy offers direct visualization and targeted biopsies of suspicious peritoneal surfaces. FTC is broadly categorized based on histologic phenotype. The serous type, encompassing greater than 70% of cases, mirrors high-grade serous ovarian carcinoma with papillary structures, marked nuclear atypia, and frequent TP53 mutations. Non-serous subtypes include clear cell, endometrioid, and mucinous variants, each possessing distinct morphological and molecular traits. Clear cell FTC often exhibits glycogen-rich cytoplasm and may be associated with endometriosis. Endometrioid FTC shares features with endometrial carcinoma, such as hormone receptor positivity. Mucinous FTC produces abundant mucin, resembling intestinal-type tumors. These classifications guide therapeutic decisions. For example, clear cell tumors may respond better to platinum-based regimens, while serous tumors frequently benefit from PARP inhibitors in the presence of homologous recombination deficiency. Management of FTC is multimodal and stage-dependent. Primary surgical cytoreduction aims to achieve no gross residual disease. In early-stage disease, a unilateral salpingectomy removal of the affected tube may suffice, however. Most surgeons opt for total hysterectomy with bilateral salpingo-oophorectomy and systematic pelvic para-aortic lymphadenectomy, mirroring ovarian cancer protocols. Post-operative platinum taxane chemotherapy, for example carboplatin plus paclitaxel, is standard for stages 2 to 4, improving progression-free survival. For BRCA mutated or homologous recombination deficient tumors, maintenance therapy with PARP inhibitors olaparib and niraparib has demonstrated durable responses. Radiation therapy plays a limited role, but may be employed for isolated pelvic recurrences. Multidisciplinary care, integrating gynecologic oncology, medical oncology, radiology, and pathology, is essential for optimal outcomes. Because the underlying etiology of FTC is often hereditary, primary prevention focuses on risk reduction strategies for high-risk women. Genetic counseling and testing for BRCA12 and other homologous recombination genes enable identification of carriers. For confirmed carriers, prophylactic bilateral salpingectomy, removing both fallopian tubes while preserving the ovaries, has emerged as an effective risk-lowering measure, especially when performed during a benign hysterectomy or sterilization procedure. Some guidelines also recommend opportunistic salpingectomy during cesarean delivery or tubal ligation. Regular pelvic examinations, transvaginal ultrasound surveillance, and serum CA125 monitoring may aid early detection, although no validated screening protocol exists for FTC alone. Lifestyle modifications, such as maintaining a healthy weight and limiting exogenous estrogen exposure, are adjunctive but lack robust evidence. Prognostic outlook in FTC hinges on the stage at diagnosis and molecular profile. Patients with disease confined to the fallopian tube stage enjoy a 5-year overall survival of 70 to 80%, reflecting the benefit of complete surgical resection. Once the cancer spreads beyond the tube into the peritoneum, ovary, or distant sites, survival drops sharply, with 5-year rates falling below 30% for stage 3/4 disease. Presence of BRCA mutations, while increasing risk, can be a double-edged sword. These tumors often respond well to PARP inhibitor therapy, potentially improving outcomes. Conversely, high-grade serous histology and residual disease after surgery portend poorer survival. Ongoing follow-up typically includes periodic imaging and clinical evaluation every 3 to 6 months for the first 2 years, then annually. The past decade has seen rapid advances that reshape FTC management. Molecular profiling now routinely identifies homologous recombination deficiencies, enabling personalized therapy with PARP inhibitors. Trials such as SOLO-1 and PRIMA have extended these benefits to tubal carcinoma patients harboring BRCA mutations. Liquid biopsy technology detecting circulating tumor DNA or tumor-derived exosomes in peripheral blood is under investigation as a non-invasive early detection tool and for monitoring treatment response. Early results suggest that ctDNA levels correlate with tumor burden and may predict recurrence before radiologic evidence. Additionally, the concept of opportunistic salpingectomy, removing fallopian tubes during any pelvic surgery, has gained traction as a population